Oh, I didn't do
You
it.
didn't do it.
I didn't do it. Remember, I'm slow.
There we go.
All right. 60 minutes. Okay. How do we get here? Okay. So in what is known as early view, both the journals, like some of the journals have an early view publication. This just came out last week, where this very nice article that I recommend to all of you. This is the ability to take patients with short bowel syndrome or patients who have rather enlarged small intestines because of this motility issues over the years, that you can do a transverse enteroplasty and increase the length and allow for improved peristalsis, so that individuals that are now dependent on total parenteral nutrition can be weaned off, or at least decrease the run time for TPN. But what I wanted to give kudos to was the nutrition support team at Emory, because they're highlighted in this as being a big component of the success of being able to do that, because they had both the inpatient and the outpatient. And as you know, and I hope that Allison will address, is the difficulty that we have when we have patients in the hospital well taken care of, and then they leave the hospital and everything turns to caca grande, if you know what I mean. So let's look at the legal system. Basically, you have the criminal and civil branches. Usually when we talk about malpractice, and we can talk specific about that later, this is a unintentional tort or harm, and it's negligence. There are other issues that can come up in your sphere, not often, that have to do with contract, perhaps abandonment, are issues. But from a end-of-life care, which is how I got involved in this, and we got involved early, there are three major cases that have come up, okay? The equivalent case in '76 had nothing to do with nutrition. It was a ventilator issue, but they established ethics committees and established living wills. Then in 1990, we had the case of Nancy Cruzan that established the autonomy of the states to make the law, and also established that artificial administered nutrition and hydration, EN and PN, was a medical therapy no different than hemodialysis and ventilators. It also established the need for advanced directives. Then the chaos of the Teresa Shawa case in 2005 that further refined our advanced directives as it regards to nutrition and hydration. Now, there have been other aspects of law as it relates to end-of-life care and as nutrition, and one of them dealt with a Hustle verdict. Dr. Hustle was a critical care physician who, in trying to, quote, comfort his patients, provided huge doses of narcotics for terminal extubation, and he was accused of murder, criminal, okay? He was acquitted, but yet had to settle in a civil suit with 17 of the other families. More recently, and sadly here in the state, we had the shooting in Winder, Georgia. And again, just to show you another dimension of the law, this is the doctrine of vicarious liability, which is similar to the doctrine known as respondent superior, which means that your actions while you're employed, if you have a negligent act, you are usually not held responsible for it. It is your employer that does. So I urge you to know what your particular institution coverage is for you in that realm, so that if you, for some reason, provide the wrong formula or there's an adverse event, you know who is responsible. Most of the time, is your employer. The thing that's unique about the Georgia case is that it'll be the second time that this doctrine is applied to a parent regarding the actions of a child. So much for the technology, so much for the law. Let's go to the nitty-gritty here. Morals and ethics. Most of the time, we use it interchangeably. But let's just, for the sake of discussion, say that morals are pretty much the standards of behavior, right or wrong. while ethics is the application of those standards as rules. And to me, is as though morals are the policies and ethics are the procedures. That branch of ethics that deal with research and medicine, healthcare, is known as bioethics. And through the centuries, there have been multiple theories. Three of the more popular ones, if you will, are the virtue ethics that says that right or wrong is based on the virtuous man or person with characteristics, whether it's fidelity, courage, honesty, etc. Immanuel Kant proposed that we had an absolute duty. So you should never lie, period. You should provide nutrition support no matter what, whether it's a patient in coma or what have you. And then what I think is more practical is the utilitarianism or consequentialism theory of Stuart Mill. And this is in direct opposite to the ontology or the duty. This says consequences, not the intentions, is what provides ethical valence. Now, by example, virtue would say to a patient in a vegetative state, let's do a limited trial to see if this works. And that's demonstrating, respect, compassion, respect for autonomy, if you will. While the second one, as I said before, provides that the therapy will be available to all and must continue until death. Lastly, you would have the utilitarianism concept that is the greatest good for the larger number. This has to do sometimes with resource allocations. This has to do with benefits versus risks. In the early 70s, Beauchamp and Childress kind of took all of these theories and put it together into an approach. It's called the principalism approach. It is what we currently use in the United States and in many other Western societies. And it's composed of 4 elements, all 4 having the same weight. First is autonomy, the ability to provide self-determination. If a patient is of age, 18, in some cases 21, and is competent and capable, then they should have the right to make a determination. And there's a side to that we can discuss later, which is you too, as a professional, have a determination, autonomy. So what happens if you're in conflict with what your patient wants? Just because they have a right to make a decision of what will be done to their body, they cannot demand that you violate your own autonomy. So what happens in that dilemma? Second is we always want to do what's the best interest in our patients, beneficence. Third, to do no harm, like Hippocrates told us, the so-called primum non nocere. And some people have said this is in contrast to primum pecunia facere, which means, first of all, make money. Distributive justice is fair treatment with equitable process. I'm not going to get into political discussion here, but one of the things that today bothers me is the confusion that exists between equality and equity. And within equity, the confusion that exists from one individual to the other. And I like to look at that second paragraph. At least for me, it makes sense that what equity is all about is that each person has a certain goal that they want to achieve, an outcome. And to get there, they need certain specific accommodations to their needs. Okay? And so that's my little pitch about justice and fairness. COVID-19 was a rough time for most of you or all of you. In a way, I felt fortunate that I was not in practice anymore or doing my administrative work. But it did prompt someone to ask me to look at this and see what we could muster in terms of, how do we deal with resource allocation in an ethical fashion? And I found out that there was a need to develop a priori protocols that limited with this, dealt with this whole issue of limited resources, whether it was supply, capacity, personnel, and to that end, to develop those protocols, there need to be an ethical framework. And then from that, once you had that protocol in place, that it would be good to have a triage team that was not the nutrition support team or the bedside team to make the decision. Because that way, even though you had the input of these individuals ahead of time, you wouldn't have to have the emotional latent activity in addition to caring for these patients to have to decide who gets what and who doesn't get it. So to that end, here's an example from White regarding bioethics and an ethical framework. First of all, that the benefits should be maximized. Second, that priority should be given to those of us that are in healthcare. Because we do not survive, we're not going to be able to provide care to others. Another exception or another priority would be given to those individuals who participated in research, for instance. And that there was no differentiation between patients that had COVID versus those that had other medical conditions. Let's say they had emphysema and needed a ventilator. You know, who gets it? Who doesn't if we had limited? There was also a proposal that to help with this framework, if we could have some objective data, and certainly a scorecard was developed or was recommended based on current criteria for criticality and predictable mortality or survival, with the Apache score or the SOFA scores that we often use in the critical arenas. And then this is tied into comorbidities that individuals may exhibit and the expected survival from those comorbidities. And so that was the case with COVID-19. And thank God, you know, we didn't have to see too many resource allocations. But I urge you to think about this and begin the process of developing such protocols within your institution and see how much support you may get from others. Let's look now at bioethics in specific conditions. End of life, withhold and withdrawal. Most theologians, ethicists, clinicians will tell you there's no difference. However, withdrawing something, whether it's a tube feed, whether it's a medicine from a loved one, is fraught with a lot of emotionality. And so it's important that we have some advanced directives that guides us in that realm, and that we have evidence-based recommendations and have those crucial conversations with our patient in a patient-centered and family-centered environment as proposed by Denise Schwartz, who I hope is on the line, and I hope she'll comment with us later. But one of the good resources of this is the National Healthcare Decision Day website. National Healthcare Decision Day occurs April 16th every year. Easy to remember. The two things that we know for sure in life, death and taxes. So you pay your taxes on the 15th and you die on the 16th. All right? So you go to the site. And by the way, how many of you think that patients should have an advance directive? Show of hands. I would say practically everybody. Now, how many of you have an advance directive? All right. So the lazy ones, get busy. All right. Because if you don't think, if you think you're going to be here tomorrow, that's not a certainty. Okay. And you would create a lot of burdens for your loved ones. So go there, go to the state, check your own advance directives and work on them. The other question that comes up is advanced dementia. Is the patient competent? Do they have decisional capacity? Competence is usually a legal term determined by the courts, while capacity is more clinical. And capacity can be something, in some institutions, you cannot make a decision for yourself if you've had a narcotic, and you have to wait 3 or 4 hours before you can make decisions. The Demented patient can be partially incapacitated, meaning that they can only have a proxy make decisions for healthcare decisions, while their finances may be fine. They may be able to balance a checkbook, or vice versa. So there are clinicians, such as psychiatrists and neurologists, that should make that determination before you proceed to necessarily write them off, if you will. Let's find out what is the status of the mental capacity at the time that we're trying to make critical decisions for them. As far as the permanent vegetative state or minimally conscious states, as it is now called, I guide you or lead you to the article regarding the position paper from Aspen, again authored by Denise and a cast of thousands, and asking the question of how permanent. I was just reading a recent consensus of the Neurology Society, as well as the Critical Care Medicine, and I think Pediatrics, that has provided New York guidelines or refined guidelines as far as brain death, published this year based on guidelines from 2023 that you should perhaps review. And then the question comes up about tube feedings and gastrostomy tube, and I call it to be or not to be. Now, how many of you think that we are overutilizing PEG tubes? Okay, how many of you think that we are underutilizing PEG tubes? All right, so we have just a smattering of people that think we're overutilizing. How many of you think that PEG tubes are being properly utilized? So I would say that the tendency is that you think that in certain cases they are being overutilized. Well, I want to agree with you, and unless things have changed in the last 6 years, the usual thing is that a patient's family is called long distance, and it's not in the rush of the conversation, not given all the pros and cons of the procedure, not the risks, the benefits, the alternatives, what would happen with, what would happen without, and the more critical conversation that tube feeding is not going to help your loved one survive. And if anything, it's going to make it worse. And here's why. In those minute cases, in those few cases, I think it's important to share as much information as possible. And if you're not capable of doing that, get someone else, whether it's a chaplain, whether it's an ethicist in your group, whether it's somebody else. As I said before, when in doubt, consult. And so here is a patient-directed pamphlet or a one-page on feeding tubes with Alzheimer's, patients with Alzheimer's by the American Board of Internal Medicine Foundation. So the question I always have, and something that I propose all the time, is time-limited trial. What is that? That says, I'm not sure as a clinician, I'm not sure as a nutrition support team, whether or not TPN will help you or tube feeding will help you. I like to try for a few days. But I caution you that you need to set the stage ahead of time with the family. You say to them, we have a therapy that may or may not help. We want to try it. But when we decide that it's no longer providing a good yield, when we feel what others call futile, then we're going to disconnect it without consulting you. So you don't have to be burdened emotionally about this. In this way, we're not depriving the patients of the potential of a beneficial intervention. Now, the other thing that happened in what I call the circus of the shower case is this business of taking the tube out, going to court, no, put it back in, no, take it out, put it back in, take it out. So when in doubt, don't take it out until all the parties have come together, all the T's are crossed, all the I's are dotted. We used to have a say many years ago that where there's a will, there's usually a large family. And they come out of the woodwork at the very, you know, what do you mean? I had the power of attorney. What do you mean you intubated her? She wasn't supposed to be intubated. Anyway, you know what I mean. I had a personal experience 3 months ago. And Allison was very helpful in that endeavor. We lost our daughter-in-law. This is her advance directive. We helped her because this is similar to my advance directive. I do not want to receive nutrition and fluids by tube or other medical means. Now, this is Maryland, but the Georgia is almost the same. But I had, unless this healthcare team feels it would be beneficial, at least on a trial basis. If and when my healthcare team determines that artificially administered nutrition and hydration is no longer a benefit, then it should be discontinued. So I am a big proponent of time-limited trials under those circumstances. So let's go back now, look at the whole scheme. We have the troubling trichotomy. We know that we need those crucial conversations. We need this team to act in a transdisciplinary way, cross-functioning. So the dietitian is not here. Somebody else picks up the field. Let's bring in the in addition to the core four, if we have them, let's bring in the family, or let's bring in the ethicist, or let's bring in the chaplain. Now, we are consumed every day, as you saw from the nutrition support teams, taking care of our patients at the bedside. We're consumed with their safety. We're consumed with decreasing infection, showing value, et cetera, et cetera. And so we have these three pillars of the T3 that provide the troubling trichotomy to support us as teams, to support us as clinical professionals, as we deal on a daily basis with disease-related malnutrition, whether it's be from acute or chronic inflammation. And as a side, assuring that there's nutrition care access in our hospitals. I refer to that conundrum or that approach as the clinical dimension of T3. What I want to challenge you today is that there's another dimension that you may not have thought about, but we must do if we're going to be successful in eradicating or minimizing malnutrition throughout the world, throughout our institutions, to be able to show that malnutrition can be defeated, at least in part, if not all. And that is an ethical dimension that requires a little bit more. As opposed to the obligation to the bedside patient, this obligation is to yourself, to your peers, and to the community at large. So this ethical dimension of T3 may include a cadre of things. Some overlap, but in technology, what type of research are you doing? Are you ethical in the approach to the methodology? Are you aware of the Tuskegee Institute syphilis study, the Nuremberg trials, the Helsinki Accord? How well are you at demonstrating the potential of conflict of interest? How often do you make sure that you're not plagiarizing in your reports? In terms of ethics, of course, we know about end of life and principalism. We just talked about it. But what about your professional ethics? When was the last time that you checked on the ADA or A&D website the professional ethics and the competencies that you should have? How hard are you trying to keep up with the literature and keep up with your practice so you're actually working within the licensure, but at top of licensure? How much do you know about informed consent? I was glad to see the Emory presentation regarding how they have developed an informed consent for parental nutrition that lays out the pros and cons, et cetera. And so as nutritional teams and as nutritional professionals, as we move into this ethical dimension, on the one hand, we want to talk about the awareness, prevention, management of DRM. We need to be champions for health promotion, disease prevention, research, and more dated up to date the global malnutrition composite score that we'll talk about in a minute. On the other hand, advocating with our representatives, with our senators, with our colleagues, differentiating equality from equity, providing new diagnostic tools, educating the public, administrators, health professionals. And then we can talk about an activity that has taken international interest, and that is the development of a group that is an international working group for patients' right to nutritional care. And several articles have been proposed, and those are in the handouts. So in 1948, the United Nations determined that everyone should have a right to food and a right to health care. But nutritional care is a little bit different, because nutritional care, just like the global malnutrition score, looks at screening for malnutrition, the diagnosis, assessment and surrogate diagnosis, a treatment plan, and then a follow-up. And so in 2022, based on earlier declarations from the FALAMPA, the Federation of Latin American Societies, declarations on human rights, through the GASPEN organization, the European Society, this Vienna Declaration was signed on by over 120 societies. And basically, what it calls for is that everyone in the world should have nutritional care access. And as you can see, there are several of the groups, including GASPEN, and I represent GASPEN along with Juan Ochoa. And here from Atlanta, you also have Teresa Pounds representing the West African Society for International Nutrition on this task force. And again, these are the components of it. But it moves from our T3 approach of ethics and principalism at the bedside to what is known the human rights and FRIDA principles. And again, I won't have time to go through all of them, but FRIDA stands for fairness, respect, equity, dignity, and autonomy. And more recently, 4 days ago, we had an we had another Zoom conference that we have frequently. And now we're looking at low income and middle income communities throughout the world and how we can adapt guidelines so that they can use it. And we were joined by representatives from the representatives from the Doctors Without Borders. But others have reached out to the World Health Organization and so on with the hopes that we can make an impact at the international level. Again, someone had addressed this earlier, I believe, maybe Laura, presenting about next week's Malnutrition Awareness Week. And I want to make sure that you know about the Global Malnutrition Composite Score, because this is the first time that we had a measure of quality for hospitals that had to specifically deal with nutrition. And I would encourage you, again, to befriend whoever is in charge, whether it's an administrator or someone in the quality department, to see if your hospital will choose this as one of the indicators, because if you do it right, and you can then demonstrate that you're following that EQM, electronic quality measure, your hospital will get better reimbursement, or at least it will not be penalized by having withdrawn some of the Medicare reimbursement. And it'll enhance your position in the eyes of everyone in the institution. And so each year, for several years, GASPEN, when they get the Malnutrition Awareness Week schedule, calls on all the societies, all the states, to get a proclamation from their government. And for the last 3 or 4 years, I have been the one to do that. And just earlier today, I presented Laura with a proclamation for this year. And you can pass it around or show it to her. You can see it here on the slide. And I'm very appreciative that Laura, on behalf of GASPEN, has agreed to take on that job starting next year. And I'll give you all the, it's easy to do. The folks at the home office at GASPEN are very, very gracious, and it's a no-brainer, as they say. Now, By now, you should know that I am prejudiced towards dietitians. All right. When you look at all the changes that have occurred in the last 5 decades, the one constant has always been the dietitian. Right? We started with doctors and love. There was always a dietitian. Right? The doctors went away. The nurses got thrown to the home infusion companies that could no longer be specialists in the hospital. The pharmacist doing his job, but it's always the dietitian that is related to nutrition. And so, to me, as I have here, you're dedicated, intelligent, experienced. You're a team member, transdisciplinary, but more important, next to the last bullet, committed. And again, as you're looking for someone to be hired as a new nutrition support team, like was alluded to earlier, we need the body, but we need a committed body. You know, you don't want someone. And by the way, this morning, I get this Medscape notes, and this morning's article dealt with the fact that PAs and nurse practitioners in increasing rates are now quietly quitting. You've heard that term, quietly quitting? These are the people, the opposite of commitment. I'm going to do just what I need to do because when I go above and beyond, I'm not being appreciated. All right? This is a real thing. People get frustrated if you're not praised or you're not thanked, if you're not treated with respect in your environment. Again, the ethical dimension. So when you go home, if you work with a nurse practitioner or PA, give him a big hug. Or her. Big hug, don't say anything, move on. What the hell was that about? Huh? Okay? So I'm not going to, anyway, don't be a chicken. Okay? I'm not going to tell you what to be, but don't be a chicken. Be committed. And this goes also for the rest of the teams. Demonstrate value. Okay? Demonstrate the service, the person-centered care. Demonstrate the risk mitigation, that you prevented a negligent act, that you were able to communicate with the family that felt that the doctor or the nurse or this one did that and the other, that you were able to smooth the waters, that you listened. Most patients in end of life don't want to hear from you. They want you to hear them. They want to die with people around. They do not want to be abandoned, and they don't want to be in an environment that smells. Basically, that's what Dr. Kubler-Ross taught us many years. Oh, there want to be 2 minutes left. I have 2 minutes left. All right, so why am I saying this? Again, if you're not at the table, you will be on the menu. How many of you are part of an ethics committee in your hospitals? None. Oh, one. Okay. Volunteer or you were forced to? Good, good. Because there's volunteer and there's voluntold, right? So you're not going to be invited to the ethics committee usually unless you ask. You can't win unless you play. How many of you are part of a process improvement committee? We saw some examples here from the Emory group. You got to get involved. You have to do that ethical dimension, going above and beyond. You're going to sleep better, if you get any sleep at all. But you're going to sleep better. So here is, oh, there's Denise again. She wrote that article. Okay. A nurse, Carol McGinnis, I think she's in Montana, went to her doctor, went to the medical staff, got privileges for placing a bridle, you know, the anchoring, being able to anchor tubes. She's working at top of license there. One of your dietitians, past president of GASPEN, I don't know where she is in that course, but Gail Kretschy was trying to get privileges so that she could diagnose on an x-ray the location of a tube. That's on top of the fact that many dietitians are now have the competencies for inserting tubes, just like they have competencies for performing the physical exam. But this goes beyond just the dietitians. In closing, 1 minute, right? In closing, the 12 C's: common sense, common decency, commitment, communications, consultation, collaboration, concern, consensus, care, compassion, and as we talked about earlier, comfort. So we need to comfort always. We can leave the learning questions for the Q&A, okay? Without further ado, I'll give you the expert here, Allison. She's the boss. Someone needs to fix this.
I did your sentiments. Alrighty, how do I work this? Honey child, okay. Where can I see the time? Right there. Why disappeared? What? Well, how much time do I have? How do I? Where do I see my notes? What? No? Oh. Wait, can I do it without doing this, or can I do? Okay, so this is your, okay. Okay, so, okay. Welcome everyone to my session. It's called Parenteral Nutrition at the End of Life, Adult Palliative Cases in Real Time. So I know we don't have a lot of time left, so I'll try to review this as quickly as possible. It is a lot of information, and I'm available after this if you want to chat or need references or what have you. So I have no disclosures. And so our learning objectives is to apply demonstrated best clinical practices aligned with evidence-based medicine. That's what we do, right? To improve practice gaps for adult patients on parenteral nutrition in the end-of-life setting. And we're going to discuss bioethical concepts with a focus on the 4 core ethical principles. Dr. Barocas described them. So maybe we don't have to go through all of those, but and we're going to summarize case studies in real time. And these are real, real case studies that happened in my clinical practice. Describe nutrition support clinicians' role throughout transitions of care for the patient on PN with serious illness and life-limited expectancy. So all journeys begin with a story, right? And going on the journey with this patient population is very rewarding, to say the least. I've covered probably every patient spectrum there is, but these kind of hit home. And you all, even though if you're not following them for PN, you've probably seen them on your initial nutrition screen, you've offered them supplements, optimizing their oral, their enteral, and then they eventually land on PN. Most of these patients have like malignant bowel obstructions. They've had malabsorption. Now they have a cancer or horrific cancer diagnosis. So this is kind of, but this is the patient that originally sparked my interest on the outpatient basis. And so she was a 65-year-old female, ovarian cancer, extensive peritoneal disease, a malignant bowel obstruction. She has a G2 for decompression. She had been on home PN for about 1 year. So I was at the home infusion company. This was my patient. And talk about nutrition support teams on the outpatient sector, you really kind of create your own. So here you are, the nutrition support dietitian, your pharmacist came from retail, you have a doctor somewhere managing, authorizing the PN. So you kind of put them in the spotlight and you bring them on board, whether they really want to or not. So it does take a team. So she was admitted to hospice. So I knew this patient well, we become like family. She was admitted to the hospital, exacerbation of cancer related symptoms. And then she was slated not to undergo any further cancer treatments and slated for hospice. So, and then this particular patient with this particular hospice was deemed to go home on parenteral nutrition. So, but 1 week later at home, the husband called me. So they went home with their infusion provider and the hospice team. He called me and he was honestly crying. And he said, he had concerns that the TPN had to be discontinued. So what happened? So this was my first encounter with the outpatient home hospice team, and I didn't know who was involved, who to contact. Um, so I eventually couldn't get a hold of anyone. So I was routed to the hospice medical director. I introduced myself, and we collaborated and just discussed, goals of care. I discussed the concerns of the husband, and so we came to an agreement that the patient, who was at the center of all decision making and was still coherent and able to make her decisions, we decided that no, we would not discontinue the TPN and that she could continue it because she couldn't eat and absorb anything. And this is a patient, she had been on TPN for a year dealing with this horrific disease process. So we decided our plan was to dispense PN week by week, evaluate her quality of life parameters, considering her wishes, and the ongoing risk benefit analysis of parenteral nutrition. So this was a discovery for me. Like, it's a new practice environment. I do like new stuff. So, and this is why, parenteral nutrition support is ongoing, interesting. So that's why I've done it for 28 years, because there's always something else. So this was a new practice environment for the nutrition support clinician in home infusion, a patient on home PN and home hospice. So, and then there's a whole home hospice team. Do you have a formal bioethics committee? Not really. Do you have a formal nutrition support team? Not really. So you make them. And hospice shifts focus to symptom management and quality of life for those patients with a life expectancy of less than 6 months or less. So what happened? What was the outcome? So the home infusion nutrition support team, the home hospice clinical team, it was a synergistic relationship via a patient-centered approach. We shared knowledge, expertise, decision-making, transdisciplinary, involving the patients and the surrogate decision makers, which was the patient and her husband. He was heavily involved. What was the outcome? Safe and appropriate provision of home PN in the end of life setting. Did I sign off? Did we just dispense the TPN out of the home infusion pharmacy without the nutrition support clinician being involved? Absolutely not. So what are bioethical principles driving clinical decision making? So certainly when you're discuss these early decisions with patients with these, these life-threatening illnesses and life-limiting illnesses, early communications are prudent. Looking at their advance directives, do you have one? Do you want to create one? Preventative ethics, looking at that. What are the patient preferences? Just like Dr. Barocas showed, on the screen previously. And it's a shared decision-making process, and the patient needs to know what's going on. And we have to take that time. Considering where is the patient right now with their quality of life? What are their goals? Do they want to see their first grandchild? And we'll talk about a case study, you'll see. And exploring and respecting their values, their cultural and religious diversity, and the application of health equity and literacy. Are they understanding what you're saying? How can you put it so they can clearly understand and have time to make these decisions? It's a collaborative, proactive, transprofessional, transdisciplinary process. And we need to protocolize, write this down in the meta. I spoke with the patient. This took place. And so we've already discussed this intensively today, but the transprofessional, transdisciplinary environment, incorporating into our daily nutrition practices. And it makes a whole, and it's like Dr. Brocas and everyone has said, it's a higher level of collaboration. And All right. So what are the 4 core ethical principles? Dr. Barocas did touch on these, and this is our clinician obligation. These are nationally recognized principles and most applicable to nutrition support practice. And there's autonomy, respecting their preferences. Can they adequately make a decision, providing beneficence, providing in the best interest of the patient? Patient may want something, but it may not be in their best interest, or so having those conversations and obviously doing no harm and justice, fair and equitable treatment for every patient, no matter what. So this advanced planning and early conversations require active listening, and the patients want to be heard. They have a voice. And when in my home infusion practice, I tell them, you're at the center of everything I do. And they can't believe it, really. They're like, wow, okay, she cares. And therapeutic silence, just listening and validating their choices and feelings, and providing, this is important, if you're practicing nutrition support in in patients in life-limiting illness, anticipatory guidance. And you'll see this in one of my case studies. So benefit versus risk and the burden analysis. And when a patient gets to a certain point where the PN is obviously, the disease process is exacerbated, the tumor is, depending on the growth of the tumor, you get to a place where PN is really futile. And it's not what you've done as a clinician, but it's the disease process. And you talk about that's, when you barely have a blood pressure, or when you're vomiting, or whatever, stool, your fistula or whatever's happening, we have to consider holding it and reevaluating it. Holding is a kind of a less invasive way to, have those discussions, because holding doesn't mean stopping. And then the teach back method, which is described in the ASPEN ethical aspects of artificially administered nutrition and hydration, the ASPEN position paper published in 2021. Denise Baird Schwartz, Dr. Barocas, that's a great article if you need to have that in your collection. So, and discussing and reevaluating PN throughout the trajectory of the life-limiting illness is crucial. So when do we consider PN and life-limiting illness as a palliative intervention? And if you look at the ASPEN consensus paper from 2017, it gives you where to start. So do they have a GI condition precluding oral and enteral? Clinically, are they medically stable? If you don't have, if you're not medically stable and under any condition, we don't initiate PN. What is their performance status? A Karnofsky score greater than or equal to 50 for adults, and then expected survival 2 to 3 months. If they're expected to survive over the weekend, obviously, we need to have probably an alternate plan. Monitoring follow-up, adherence to if you're going to, consider parenteral nutrition, adherence to a scheduled lab monitoring, cath care every week, and caregiver support, infusion procedures. So, and then obviously, realistic expectations and comprehension. So what are the prerequisites according to ESPEN, the European Society of Parenteral and Enteral Nutrition? An indication for a medical treatment. So we know that parenteral nutrition is a medical treatment. A predefined and achievable treatment goal. We need treatment goals, right? Professional obligations and standards. What is the appropriate treatment? So end of life is the same. You're looking at a patient with a Whipple. You're going to apply your professional obligations and national standards, and you're going to weigh specific benefits versus risks, burdens, consideration, quality of life, psychological, religious, spiritual well-being, and the will of the patient, informed consent. So what are the potential benefits of PN? We know in modern day parenteral nutrition, we can really make a difference. We can stabilize their fluid situation, their electrolyte homeostasis, we can give nutrients for energy, increase, improve activities of daily living. We can really, favorably impact their quality of life, improve mental alertness. I have some patients who, we may do a home start PN and with life limit, and we're there and, 5 days later, they're having more quality conversations with their family members. They're getting out of bed. And they have time with family and friends. They're present for important life events. They want to see their grandchild, or they want to see their grandchild graduate, whatever it is. They want to travel one last time, and finalize legal matters. These are super important things. So what are the risks and burdens of PN, both clinical and quality of life? There's always CAPC, but we have new, bundled education and behavioral interventions to mitigate line infections. We, as a nutrition support clinician, we can, have the expertise to manage fluid issues. But there's always that risk. There's that patient who puts out 8 liters from a peritoneal drain every day, or, and PN might send them in more fluid overload, So electrolyte disturbances, increase urine output on infusion, so they're not sleeping at night because of their cyclical TPN. Increase, hydration can increase their GI secretions. They can have more fistula output if it's not controlled medically, or, you have to find where we're not going to, emphasize, or add to the risk, or add what I call it fuel to the fire. And then there's the burden of daily PN infusions. It can be a lot. You've got to connect, disconnect, you're on a pump. And then difficult, managing the pump. The pump's going off every day. What's happening? And then patient care partner fatigue. So what is our role, the nutrition support clinician's role in mitigating these potential complications? So like I said, we have central line bundles. And we're providing ongoing assessments. We want to use the gut where possible, but most of these patients have malignant bowel obstructions. They're going to have that. They're not having any more cancer treatment, avoiding overfeeding macronutrients, so we can deter complications associated with PN. And we really don't see these much more. We have the new generation lipids, we have ASPEN guidelines. And if you're practicing, you really, should be dosing according to ASPEN guidelines, and getting all the education you can so that you can mitigate any complications with PN. Correcting a metabolic disturbance, combining the PN and fluids. So there's one, a single infusion versus multiple infusions. Cyclical PN can add to the quality of life, and decreasing the number of additives so that, if they've been getting all of these extra nutrients in the bag, like B6 or folate and this and that, because those are placed in the bag in the home by the patient. So, but just remember, they always need IV MVI. So what do ASPEN guidelines say about cancer patients and palliative care parenteral nutrition? So clinical practice, contraindications, complications, and managing and monitoring PN doesn't differ between cancer patients and patients living with benign disease. We monitor the same way. They don't just go to hospice and there's no one to manage or help with the parenteral nutrition, because we know they need us actually. So, and long-term home PN programs are including these patients with reasonable results. And that was a strong consensus, but timing is crucial. We don't want to wait. We want early intervention. Like we're missing the boat on, the malnutrition. We need to start early. We need to identify early malnutrition. That's a poster I wrote, but you can look at that. So the other question we always talk about is PN, or it comes up, And is PN covered in hospice? And so, this is it's really, if you look at the abstract I wrote with my colleagues, it's really a case by case, basis. And, if you're, I mean, sometimes, some hospices will cover out of their, per diem they get from insurance companies. And some of the, hospice agencies with a larger number of enrolled patients, seeking more medically complex patients will take on patients who are on parenteral nutrition. Some smaller, absolutely not. And when we called nationally around around the US asking if hospice took, patients on PN, some of them said, what is PN? So what does this mean? Is PN covered? Well, some will carve out for PN from daily rates. I've had patients pay out of pocket, and the home infusion agencies give a reasonable price. And then some hospice agencies may not provide higher cost interventions. So, it's really case by case. And I think the nutrition support dietitian or the dietitian in general, they need to be in those discussions. This patient has a malignant bowel obstruction. They have short gut. They've been on TPN for 10 years. Now they're going to hospice. Can you just stop it? And it depends on where they are with their quality of life and their goals of care and the conversations and patient autonomy. So this is my little guy. How am I doing on time? How many? Oh, well, anyway, so the patient who declined, this was a guy, they gave him 2 weeks to live. And, he had been on PN, he had a malignant bowel obstruction. He went home with an NG and hospice, he was slated to go to hospice. They offered an NG dissection, a PCA premixed multi-chamber PN bag. And I get a call that they're sitting in the hospital. What do? They call their home infusion dietitian and they say, what is the difference between the premixed without lipids and vitamins and what you're giving us? So I told them. They didn't want that. They wanted to continue their compounded parenteral nutrition bag because he can't eat and absorb. He has a large tumor sitting in non-resectable. So the patient had intact decision-making. He conveyed his ongoing life goals despite the estimation that he would only live for 2 weeks. So what happened? He declined hospice. Did he need it? Yes. The hospice teams are amazing. But he went home with palliative care and MWA and the home PN per the infusion pharmacy. He ended up living 7 more months. And he honestly only went in the hospital 1 time during that 7 months to get his NG replaced. But so he attended his daughter's wedding and he held his first grandchild. And this is a guy, he's a 61-year-old, high-grade mucinous appendiceal cancer, peritoneal mets. He had the high-pack chemo. He had recurrence in his small bowel. He had an obstruction, and he had a non-functioning GI tract. Started PN in the hospital, on it for 30 days, and palliative care was consulted, the whole cascade of events that happens inpatient. We decided he consented to a G-tube. What were his goals? I want to go home. And so he was discharged home with hospice and PN. So what did I do? Collaborated with my team, the hospice team, my pharmacist, and we got him home. And as far as the formula, when you're sitting, they're sitting in the hospital, they're getting this anabolic, heroic PN, but when we go home with hospice, think about what you're discharging these guys on. Think about the calories. And GASPEN, their general range is what they recommend for these palliative patients is 25 to 30 cal per kg and protein. You can see on the slide. So So anyway, you can read through the case studies. I know we're running out of time. But this patient in particular, he enjoyed being at home for many months. He was walking to his pond. He was finalizing his legal matters, and he lived with a reasonable quality of life for 4 months. Could he have lived without parenteral nutrition? He couldn't eat and absorb, so no. So this was probably a slower growing tumor, and so but eventually the tumor burden was worse. He was having more symptoms from the cancer, and he was tired. And so PN was discontinued, and he expired 2 to 3 weeks later. That was a time limited trial. I'm almost done. And so again, collaboration is key. And looking at the benefits versus burdens, talking with the patient, the family, and this is what a palliative PN looks like, considering those things, and then monitoring. We monitor the same, whether they're in terminal illness in hospice or sitting in the hospital, or we monitor. They're on parenteral nutrition, so we monitor the same way as we always do. And so when does our role start and when does it stop? Well, it doesn't. It starts, and we follow it's crucial for us to follow throughout all care transitions and continuum of care for the patient on PN. So my conclusion is ethical principles must guide clinical decision-making, patients' interests, benefit versus risk burdens, evidence-based medicine, and demonstrated best practices. If you don't know, like we've said, ask, call your peers, ask your doctors, collaborate. Share knowledge and expertise, integrate, and involve the patient and the family. And if they're on PN and life-limiting illness, we want the safest following GASPEN guidelines to mitigate complications, education, and early discussions, and then final informed decisions. And that concludes my presentation. Of course, I could talk for 3 more hours, but you can find me on LinkedIn.
And I know Allison and Dr. Brokus would be more than happy to take questions. Now that we do have to, for a couple minutes over, so we don't have time for questions.
I don't want to quit. Okay.
So thank you, Allison. So they'll be up here if anyone has questions. Real quick. So